Aortic Aneurysm, or as we often call AAA, and aortic dissection. Now, these are fairly serious conditions, and they carry a very large mortality, something that you guys may only encounter once or twice throughout your careers. There we go. So what we're dealing with essentially is a high pressure pipe. If we think about the normal systolic pressure of 120 millimeters of mercury, that corresponds to a water column about 1.6 meters high, 160 centimeters high. And you can appreciate that a rupture or tear in a pipe with that pressure is going to cause a lot of leakage very fast, resulting in a very high flow. So before we get started, I just want to go over some objectives of this lecture. For both aortic dissection and AAAs, I want you to appreciate the associated risk factors and prevalence. I want you to be able to understand the pathophysiology behind these conditions and also describe the similarities and differences in clinical presentations. I want you to be able to describe the complications that can occur with both of these conditions, and also appreciate and demonstrate the appropriate principles of pre-hospital management of patients with both AAA and dissection. Lastly, another thing we're going to touch on are the differences in presentation between aortic dissection and MI, and appreciate that there's a lot of difficulty in differentiating between these two. It's something that even as emergency doctors in the department, we have difficulty with, and even with our diagnostic imaging, we sometimes have trouble. Before we get started, I'd like to go over some aortic anatomy. The image on the left shows the course of the aorta from the aortic valve, which starts at the left ventricle and descends all the way to the bifurcation of the iliac vessels at the pelvic brim. Now, some important vessels coming off of the aorta are as follows. It's not included in this image, but right after the aortic valve are the two coronary arteries, which supply blood to the heart muscle. And then at the aortic arch, we have three vessels coming off, the brachioencephalic, the left carotid, and the subclavian artery. These supply blood to both the upper limbs and also to the brain. Once the aorta descends into the abdomen, we have multiple vessels coming off. We have the renal vessels, which supply blood to the kidneys, as well as three vessels, the celiac, the superior mesenteric, and the inferior mesenteric, that supply blood to the other abdominal organs and also to the bowel. The diagram on the right, this shows a cross-section of the aorta, very simplified, and it's three basic layers. The tunica intima, the innermost layer, which is has the endothelial wall of the side that is up against the blood flow, and as well as an inner elastic layer. The tunica media is composed of smooth muscle and provides some support. And lastly, the tunica externa, which is mostly connective tissue and further provides support. Now, on to our cases. So for the first case, you get called code 4 to a home where a 67-year-old male is experiencing sudden onset severe back pain and right flank pain. He has nausea, vomiting, and lightheadedness, and his medical history is significant for coronary artery disease, as well as the fact that he's a long-standing smoker. On assessment, you see an elderly male in significant distress. He's diaphoretic and tachypnic. His vitals are as follows. His heart rate's 135. His blood pressure is 101 on 52. His respiratory rate is 30. He's afebrile, and his saturations are 94% on room air. Neurological exams reveals that he's agitated and confused with a GCS of 14. Chest examination is normal with air entry bilaterally. He has a faint wheeze, and his abdomen shows moderate diffuse tenderness with a pulsatile mass above the umbilicus. And you appreciate on his skin, there's bruising to the right flank area. So some of the things that would be going through my mind with this presentation as a differential, when it comes to lower back pain and hypotension, we think of a bleed. So you can bleed into your retroperitoneal area, which is the area located behind the abdominal cavity. In women, we have to be concerned about obstetric or gynecological pain. We also think of pyelonephritis, which is an infection of the kidneys, causing somebody to be septic. We also think of a ruptured AAA, and then obviously trauma has to be considered as well with blunt trauma to the back or flank. So, as you might have known, this case is one of the possible presentations of a AAA. And a AAA is defined as abnormal dilation of the aorta greater than 50% of normal. So this is usually defined as more than 3 centimeters in diameter. And these are relatively common among the population. 4 to 9% of the population in Western developed countries have enlarged aortas, but not many of them rupture. In the States, about 12 to 15,000 per year. And so in Canada, we kind of divide that by 10, anywhere from 1,000 to about 1,500 here in Canada per year. And the incidence is actually going down because we're observing these aneurysms over time, and surgeons are electing to repair them before they rupture. So this is just a very simplified diagram of what a AAA might look like. You can see a normal aorta on the left and an enlarged aorta on the right with an aneurysmal dilation. Usually the dilation starts kind of at the renal arteries. You can see on the right. Sometimes they can go above, and sometimes even the aneurysm can extend down into the iliac vessels as well. What are the risk factors for AAA? Smoking certainly is one of the largest risk factors. In males, the condition is more prevalent, as well as age greater than 60. Caucasian race is another risk factor, as well as a history of atherosclerosis. So if they have diseases like coronary artery disease, stroke, or peripheral vascular disease, that means that they just have poor arteries throughout their entire body, and therefore they're at higher risk of developing a AAA. There's also a large component of family history. Now, surprisingly, just in my research surrounding the topic, diabetes is a negative risk factor for AAA. People with diabetes are actually somewhat protected. I tried looking up why this might be, and there is no explanation, but when they look through studies and just run the stats, it seems like people with diabetes are less likely to develop a AAA.
Perhaps it's because they're dying of complications from their diabetes, their heart disease, which is associated with diabetes, peripheral vascular disease. So as patients get older, that the aneurysm is going to expand every year, grow a little bit. So the older you are, the more likely you're going to have a larger aneurysm, which is at more risk for rupture. So perhaps the protective factor of diabetes is the fact that the majority of them don't live long enough to experience the AAA rupture.
That certainly is a good point. And it's actually shown that if you do have diabetes and a AAA, if you're one of those unlucky people, then if you do rupture, you're actually at worse mortality and worse and increased morbidity if you do rupture. So how do these develop? And really it's thought that there's altered wall biology over time, particularly with the smoking. This changes your inflammation throughout the body, and this leads to changes in the structure of the artery wall, decreased strength, decreased elasticity, more rigidity, and damage over the years. Being hypertensive and having increased pressures will obviously cause the walls of the artery to dilate. And it's thought that if you do have a AAA, these forces, this altered wall biology and also the pressures will cause you to grow by 2 to 4 millimeters per year. And this is generally what they see when they put these aneurysms under surveillance. The risk of rupture increases with size, so surgeons will elect to repair these when they get greater than about 5.5 centimeters in diameter, or if the aneurysm is rapidly increasing in size is another reason why they would operate. So, what kind of symptoms might you encounter with a patient who has AAA? Sudden onset pain is the most common manifestation, and this can occur depending on what rupture occurs, and I'll kind of go into that further over the next slide. You can get pain in the abdomen, in the back, in the flank, even the groin and the thigh. Nausea, vomiting, pre-syncope is common, especially if the patient's hypotensive. And recognize that a lot of patients won't know they have a AAA. When these aren't ruptured, they're fairly asymptomatic. And only a handful of people will actually know, yes, I have a history of AAA. lastly, as I mentioned before, hypotension is common, and this depends on where the rupture extends into and where the rupture is located. So this here is an abdominal cross section. You can see the vertebrae here. Here's the aorta and the liver, the two kidneys. And if the rupture extends posteriorly or laterally, the aorta is what we call retroperitoneal, so it's behind the abdominal cavity, which is outlined by my cursor, and it's going to fill this retroperitoneal space. This is a more confined space and will initially contain the bleed, but over time, the space can fill up with quite a bit of blood, so the patient will eventually experience hypotension. Now, this is just a sagittal diagram, which explains what happens with an anterior rupture. You can see here the aorta, if rupturing anteriorly, will actually rupture into the peritoneal cavity, the abdominal cavity, which is a much larger cavity and more expansive. Like it will accept blood much more readily, and therefore people can exsanguinate into their abdomen much more quickly, and they will get hypotensive fast. Other findings that might occur with a ruptured AAA is lower limb ischemia, depending if the rupture has extended into the iliac. So you might see a painful limb, a white limb, lack of pulses, or a cool extremity. And you can also encounter a GI bleed. So what actually happens here, this occurs more often in AAAs that have been surgically repaired. Some of the graft material might actually erode between the aorta and the bowel, and you might have free flow of blood into the bowel, resulting in a bleed.
So now it's time for our first poll question. Just going to launch that there now. So the question is, what puts a AAA at greatest risk of rupture? I'll give you some time to answer that. Halfway there, half the audience has voted. So we've got the majority of people answering when it rapidly enlarges over a short period.
And that's the correct answer. But 1/3 of people said when it reaches a size 50% greater than normal. And that's just to define a AAA. So that's our normal aortic diameter is about 2 centimeters. When it reaches 50% greater, that's 3. So that kind of is our definition of a AAA. But at that point, it's actually at very low risk of rupture. All right. So now on to our second case. This is a 72-year-old male with sudden onset of chest pain. It's sharp in quality. The patient's experiencing moderate shortness of breath as well as left-sided weakness. His medical history is significant for hypertension, and it's poorly controlled despite medication. When you arrive on scene, you see an elderly male in severe discomfort, and he's apparently short of breath. His heart rate is 72 per minute. His blood pressure is 192 on 105, a respiratory rate of 28, saturations of 95% on room air, and the patient's afebrile. Chest examination reveals air entry bilaterally. His abdomen is soft and non-tender. His neurologic status is GCS 15, except for a moderate left-sided weakness, which you can appreciate. So again, for a differential diagnosis, some of the things you should be thinking of when thinking of chest pain, obviously ACS and MI is the biggest one that comes to mind. Pulmonary embolism, or PE, a blood clot in the lungs, is up there. Dissection, which we'll talk about, is up there. Obviously consider trauma, as well as pneumothorax, either spontaneous or traumatic. This patient was one presentation for aortic dissection, and this is caused by a tear in the intima, which, as I said before, is that innermost layer of the aorta, and this leads to an accumulation of blood within the wall of the aorta. It's a very rare occurrence, with about 2.6 to 3.5 per 100,000 people per year. And as I mentioned before, this can represent a diagnostic challenge. We have trouble in the emergency department diagnosing it, and treatment for other causes of chest pain, such as ACS, may actually worsen a dissection. So this is just a schematic diagram showing how a dissection works. On the left is another cross-section of the aorta, and you can see up here there's a tear in the inner layer, and this allows blood to dissect down between the layers of the aorta. And surgically, these can be divided into two types. Type A involves the ascending aorta and the aortic arch, and type B just involves the descending aorta. And you can see that blood can actually accumulate around the throwas to these various arteries, which can present a problem that I'll talk about very shortly.
It's just interesting looking at this schematic, and you see the actual tear and blood going down between the walls here. And oftentimes patients will describe, a tearing sensation or a ripping sensation. They actually use those words, and that's exactly what is happening. The aorta itself is tearing. The blood's just kind of shearing down between the actual walls.
So risk factors for dissection include hypertension. High blood pressures within the aorta will increase the risk of a tear occurring. Atherosclerosis over time will damage the walls and make them more prone to tearing, as well as some congenital abnormalities. So some people are born with what's called a bicuspid aortic valve. The aortic valve is normally 3 leaflets. Some people only have 2 leaflets, and that puts them at increased risk of dissection. Marfan syndrome, some of you may know, is a condition where people they kind of have a tall and lanky morphology. But what this is a connective tissue disorder where their tissue elastin or elasticity is compromised. So you can imagine if their inner layer is compromised, the inner layer of their aorta, they're going to be more prone to having tears. Stimulant abuse is a huge risk factor for dissection, as this can cause severe hypertension and make somebody more prone to dissection. In studies from urban centers, in emergency urban medical centers, 30 to 35% of dissections were associated with stimulant abuse. So that's actually a very significant risk factor. Any manipulation of the heart, either via cardiac surgery or catheterization, can damage the vessel walls and also put somebody at risk of having a dissection. So on to the clinical manifestations. As Matt mentioned, chest pain that's tearing in quality is most common for a dissection, and it often will radiate through to the back. And another key point is it's maximal at onset. So it's going from 0 to the worst pain possible right away, as opposed to MI, where the chest pain can kind of be more crescendo or decrescendo, gradually waxing and waning. The back pain can also occur, as well as abdominal pain, but this is more prominent when the tear extends down into the descending aorta, and obviously then the tear would go through into the abdomen. If the carotid arteries are involved, so as I mentioned, the dissection flap itself, that flap of torn tissue, can occlude various arteries, including the carotids. And if the carotids occluded, then that part of the brain is not going to receive blood, and you'll have symptoms of stroke. You'll have symptoms of cardiac ischemia symptoms of cardiac ischemia if the coronary arteries are involved. So if that flap will cover the coronary arteries. I see we have a few questions here, so maybe we'll take those.
Yeah. So in terms of this is as you mentioned earlier, Ben, this is a difficult diagnosis to make in the pre-hospital setting, let alone in the emergency department. And as we all know, medicine would be a whole lot easier if patients presented exactly how they're supposed to in the textbooks. And we all know from our experiences, both pre-hospital and emergency department, that patients unfortunately don't have always the textbook definition of the way they're supposed to present. So these patients may just describe chest pain or have a difficult time describing what it feels like. They may say it's heavy, they may say it's pounding. at the end of the day, if you believe that this sounds like cardiac ischemia, then you're going to treat this as cardiac ischemia, because that is way more common than aortic dissections. So, that was just kind of one of the questions that did come in. Another question being, what kind of stimulants increase the risk? And it's not necessarily the type of stimulant, it's the fact that stimulants often cause the blood pressure to shoot up quite high. And the people who abuse stimulants oftentimes will have these super high blood pressures, which is just going to cause a shear force on that aorta. So the fact that these chronic users having these stimulants used, causing hypertension, kind of just a quick onset of hypertension, over time that's just going to cause continual pounding of that aorta and eventually puts them at risk for having a dissection.
Mm-hmm. So anything cocaine, methamphetamine, MDMA, I guess less likely because it's mostly a younger population with less damage to their arteries. That would usually happen in older people. But even, I'm not sure if we see it in people who are using cough and cold medicine, which can also contain stimulants.
Yeah, and not necessarily. This is probably more of the population that frequently uses them. And so unless you're, if you're abusing cough and cold medications, there's some out there do, but everyday use of them would not put you more at risk.
All right, thanks for those questions. Those are very, very good points. So this diagram just kind of shows, again, the three arteries that supply the head and the arms, and those can be occluded with a dissection flap. The diagram on the right, I really like this diagram. This shows this structure here is the aortic valve, and you can see the two coronary arteries coming right after the aortic valve. And if there's a bit of a tear, so this is your tear, and this is the space now between the layers of the aortic wall, this tear can push up and push out against the coronary artery and in fact occlude it. Now with dissection, the right coronary artery is most often going to be involved as opposed to the left, and that's just due to anatomy and structure of the heart. So things you might find on exam with dissection are hypertension. These patients are going to have high blood pressure, and even while they're dissecting, they might still have high blood pressure. However, patients could present with shock, and this is if that dissection starts to encounter some complications. If the rupture extends into the pericardial space, which is the sac around the heart muscle, and this is called cardiac tamponade. I've got a good diagram coming up showing how this works. Or you could have exsanguination into the thoracic cavity, so blood actually filling up around the lung. So you can encounter shock that way. One of the things you might appreciate is a blood pressure difference between the two arms that's greater than 20 millimeters of mercury. So it's important to check both arms. One side might have a falsely low blood pressure, and the other side might have a hypertensive blood pressure. So if you see this discrepancy between both sides, dissection should go way up on your list as much more likely. I know you guys aren't trained to listen to heart murmurs, but if the dissection extends down into the aortic valve, the aortic valve might become incompetent and might start having blood flow through it the wrong way, which on exam would show up as a murmur. And lastly, I talked about neurologic findings, so things like left-sided or right-sided weakness, a facial droop or slurred speech, or even potentially aphasia, which is the inability to talk. Those things might be encountered. Now, there is a question or a concern that, sure, if they're showing these neurologic symptoms, does that then put them into the stroke bypass pathway? And I think if you were encountering these stroke-like symptoms in the context of chest pain, then you have to consider dissection, because it's very unlikely to have a stroke that occurs with chest pain. Usually it's just the neurologic symptoms by themselves. So I would put dissection very high up if the patient complains of chest pain and also has these neurologic findings.
And just a couple of points with that there, Ben. When the patients do become hypotensive, these are gravely ill patients. I mean, it's almost to the point where we've missed the boat of being able to get them the definitive care of what they need. So once that blood starts collecting around the heart and they experience cardiac tamponade, that they're very, very sick, and as well as if they start bleeding, outside of the aorta, these are patients whose mortality is quite high, and oftentimes do not survive surgery, which is what they need. So very difficult patients once they get to that point. So and the other thing too, again, I just want to reiterate what you said about chest pain plus stroke-like symptoms is more likely to be an aortic dissection than that stroke alone. As we all know, strokes are painless. They're just a neurological deficit.
All right. This diagram here shows cardiac tamponade or pericardial effusion. You can see the dissection along the aorta here, but over here it's ruptured now into the pericardial space. And as blood fills the space, the ventricle is compressed and isn't able to fill with blood. And if it can't fill with blood, then obviously there can't be any forward flow. So at this point, as Matt mentioned, if you're encountering a patient who's hypotensive with signs of a dissection, they are very, very, very sick, and I think mortality is almost approaching 100%.
So we just have another poll question here. So the question is, what type of chest pain is most typical of aortic dissection? I'll give you a chance to answer that question. Got half voting there. We'll give it a couple more seconds here.
Excellent. So I think most people got that it is tearing chest pain radiating to the back. And yeah, that's exactly it. That it's this tearing chest pain mostly going through to the back, not always radiating, but the biggest part is this tearing or ripping sensation.
And again, as we alluded to earlier, unfortunately, not everyone's going to say all the magical words, which makes our jobs difficult, but also keeps it interesting. Mm-hmm. So they can have any type of symptom with dissection, but most commonly they describe it as chest pain ripping through or tearing through to the back.
All right. So onwards, with aortic dissection, we can experience some ECG findings. First of all, we can see inferior ischemic changes. So those are ST depression or elevation 2, 3, and AVF. And this is because, as I said before, the right coronary artery can be blocked or occluded by the dissection flap. So you might see all these things, which again further confuses us, because now we have ECG findings suggesting ischemia in the context of chest pain. So is this an MI? Is this dissection? This is always a very difficult question. You can actually see signs of tamponade on ECG, and these are electrical alternans or low voltage ECGs. And I have a couple of diagrams that show this. So this is a 12-lead ECG showing an inferior ischemic pattern. And if I were to be given this ECG and emerge, I'd call this a STEMI. But this could very well be a dissection with that right coronary artery occluded. This next ECG shows what's called electrical alternans, and you can see between each QRS complex, the amplitude changes from large to small to large to small, back and forth. And what this is that if the heart is sitting now in a bag of fluid, there's a lot of fluid around the heart muscle actually kind of can move inside that bag of fluid, and each beat, its orientation is different within that bag, and thus shows a different readout on the ECG. If you look at if you go Google or YouTube cardiac tamponade with ultrasound, you can actually see some diagrams of the heart just beating around, changing directions, and this ECG kind of describes that phenomenon. So I'm just going to go over a table kind of showing the different presentations and characteristics of ruptured AAA aortic dissection, and then I'm also going to contrast that with MI. So the pain with ruptured AAA is generally lower than that of aortic dissection. It's in the abdomen, it's in the lower back, the flank, the groin. And with dissection, the pain is located mostly through the chest to the back.
Lower back, if we're talking about a type B dissection, one involving the descending aorta. And as I've said many times, it's usually more tearing or ripping than quality. With a ruptured AAA, most often you'll encounter hypotension, but where with aortic dissection, initially the patient is usually hypertensive, then potentially might go hypotensive if they encounter one of these complications, such as a tamponade or even a rupture into the thoracic cavity. On physical exam, you might encounter bruises to the flank, an acute abdomen, a distended tender abdomen with a ruptured AAA. You might also encounter a pulsatile mass. Whereas with aortic dissection, really the one key thing you can find on physical exam is the blood pressure difference between both arms. With respect to neurologic findings, unlikely to occur with AAA unless they're very hypotensive, and that's just affecting their general level of consciousness. But you shouldn't have any focal or localized presentations. Whereas with aortic dissection, we talked about you will get, or sorry, not you will get, but you may get these more localized stroke-like neurologic findings. ECG findings with ruptured AAA include sinus tachycardia, and that's just due to the patient being in shock. But with aortic dissection, you can get inferior ischemia or electrical all-trans, which we've already talked about. Now, I'm going to touch on the differences between aortic dissection and MI. And these conditions are unfortunately, like as I said, difficult to discern, especially in the pre-hospital setting where you guys don't have any diagnostic imaging. A lot of differences, as I said, will come from the description of the pain. You know, if it's tearing versus a chest-like pressure, and even more so, you know, if it radiates to the back. But regardless, I think even with MI, you know, Matt, you can say sometimes with MIs the pain will radiate to the back. I think the key point is that I think you still have to treat these as MI unless you're fairly comfortable and certain that this is a dissection. So you know, you should be giving ASA if you still think this might be an MI or even ACS. Do you have any comments on that?
No, again, you're more commonly going to come across patients with cardiac ischemia. Aortic dissection is a rare type of event. The biggest thing is ASA is going to be so beneficial in people with ACS and cardiac ischemia that we wouldn't want you withholding from that. Again, as we've mentioned many times, aortic dissection is a very difficult diagnosis to make. And in fact, I've seen patients with aortic dissection in the emergency department and believe them to have been suffering from a STEMI and have sent them to the cath lab where it was then diagnosed as being a aortic dissection. So even with the STEMI bypasses in place, you know, I still, you know, if this patient has ST elevation in inferior leads, and, you know, I would go down the STEMI bypass route or the STEMI route for those that don't have bypass, and get on the phone and discuss with the cardiology consultant the case as you would with your STEMI bypasses. And again, like I say, sometimes these aren't even picked up until the patient's in the cath lab. At the very least, if there's no PCI available, you can want them in the emergency department where we can get some diagnostic imaging to help make that diagnosis. And again, even with the diagnostic imaging, sometimes it's not even clear cut with the chest X-rays, and in fact would require a CT scan of the chest and abdomen.
I think there have been stories, Matt, that I've heard from some of the older emergency consultants in our department here in London, where when they didn't have overnight CT and they had to make a decision between is this a heart attack or is this a dissection, and kind of having to realize that the treatment at the time for heart attacks, which is giving a thrombolytic, might actually kill a patient with a dissection because all that clot that might be starting to form in the dissection space is now obliterated by the thrombolytics, and that has happened before. Am I correct?
That has happened before in the past, and in centers that still utilize thrombolytics. So it is a difficult diagnosis to make. Yeah, absolutely.
All right. So now on to the pre-hospital or EMS management of aortic emergencies. As I'm sure I've made aware over the past half an hour, both ruptured AAA and aortic dissection are life-threatening conditions, and both these conditions require a surgeon. You know, they need to go to an emergency department first of all for assessment, but the definitive management for these conditions is a man with a knife. Pre-hospital management should be guided towards initiating resuscitation of the patient and also rapid transport to definitive care.
Just gonna have one more poll question here. So the next poll question, how might an aortic dissection cause an inferior MI pattern on ECG? We'll give you 15 seconds or so to answer that question. And it looks like the majority of people have got the question correct here, the answer right. And the correct answer being the dissection flat blocks the right coronary artery, giving that inferior MI type of pattern or inferior ischemic type of pattern.
Exactly. But a quarter answered blood in the pericardial space altering the axis of the ECG. And that can happen with dissection, but that would cause electrical alternans rather than an inferior ischemic pattern on ECG. So back to pre-hospital management. Any patient with chest pain should be getting a 12-lead ECG in the field. And though an aortic dissection might cause an inferior pattern of ischemia on ECG, as Matt said, it's really still important to be thinking about a STEMI, and you guys should be getting on the line with an interventional cardiologist. Bottom line, you're bringing them to hospital. Most centers with a cath lab will also have cardiac surgery. So if they discover on the table that, no, this is a dissection, they're still in the same place and you can get prompt treatment for that.
And for those centers without STEMI bypass, again, the best thing is getting these patients to the hospital where the diagnosis can be made and arrangements can be made for the definitive care, which, as you alluded to earlier, is a cardiac surgeon.
Certainly. If alternans is present, you got to think about tamponade, and with that, you have to be concerned about potential hemodynamic collapse. There's blood filling around the heart, and that heart is now not able to contract as well, or sorry, not able to fill as well as it should be. Now, in hypotensive patients with a presumed aortic event, so this is a patient, with a low systolic blood pressure, and you think they either have AAA or a dissection, you got to consider the source of the hypotension or the shock. So if it's a ruptured AAA, your shock is going to be hypovolemic. They're bleeding out into their abdomen or into their retroperitoneal space, and they need fluids. Well, they need blood, but for the time being, to support their blood pressure, they need fluids. If aortic dissection, the shock can come from one of a number of things. The shock could be secondary to a right coronary occlusion, and this could effectively cause an MI, leading to pump failure. And fluids might actually help with this. You might help fill a stiff heart. If the shock is secondary to rupture into the pericardial space causing tamponade, fluids will help overcome constriction around the heart. Pushing as much blood or as much fluids into the ventricle certainly will help. Lastly, if the shock is secondary to rupture into the thoracic cavity, so now blood around the lungs, this is similar to hypovolemia, and again, the treatment is fluids. So bottom line, give fluids in any patient with hypotension and a presumed aortic event. You're not going to harm them by doing this, and certainly getting fluids into them as quickly as possible will benefit them. So this is just, as you know from your guidelines, the fluid bolus protocol. Your age is most likely going to be greater than 12 years in this patient, so you can give a 20 ml per kilogram bolus. Just run it as quickly as possible. Now, once the patient arrives in the emergency department, what kind of stuff as emergency doctors are we doing? We're doing a diagnostic workup, so we're getting a chest x-ray. Some of the findings on chest x-ray for dissection is a wide and mediastinum. We're also doing point-of-care ultrasound, so that's a bedside ultrasound. In abdominal or ruptured AAA, we might see free fluid in the abdomen. In dissection, we might see fluid around the heart, or we might even see fluid in the thoracic cavity. And a lot of times, dissection is diagnosed with gold standard by CT. where we can identify that dissection flap. We will be continuing the fluid resuscitation and also administering blood products for these patients. With aortic dissection, a couple important key points that we do is we lower the blood pressure. So, as I said, these patients are often hypertensive, and that high blood pressure is just worsening that tear. It's causing the tear to further go down the aorta. And if we can lower the blood pressure with some drugs, specifically we use liable, then we can help minimize that tear. If we're suspecting cardiac tamponade, we might do a pericardiocentesis, which is inserting a needle through the chest into the space around the heart and trying to withdraw some of that fluid and relieve pressure off the heart. Lastly, we're going to be calling the surgeons. They're the ones who are going to be definitively managing these conditions, so we get them involved very early. So if these patients are to arrest, let me just preface this by saying that if a patient with a dissection or a ruptured AAA arrests, this is very, very grave. I think their mortality is approaching, if not at 100%, but these occur for the same reasons why patients are going into shock. So they're either severely hypovolemic or they have a tamponade. You have to treat this as per your medical cardiac arrest protocol. You're most likely going to be encountering a PEA rhythm, so you can still use epinephrine, you can still use fluids. Unlikely in this case to need your defib or drugs like amiodarone or lidocaine, as ventricular tachycardia or VFib is an uncommon rhythm in patients with these conditions. And obviously airway management as per your abilities. Yeah, as I mentioned, these are very bad situations, and you know, at this point it's transfer as quickly as possible, but the patient is most likely going to have a very poor outcome if arrest occurs. So, in conclusion, aortic emergencies are rare but life-threatening events. Survival and good outcomes are dependent on prompt evaluation by a surgical specialist. And for everybody out there, pre-hospital care is mostly focused on stabilization and rapid transport to the hospital. Thanks for logging on this afternoon and listening to my talk.
If there's any other questions for today's discussion, we'd be happy to answer them. And one did come in asking about some other clinical findings with cardiac tamponade. And the question came up, you know, patients with cardiac tamponade sometimes have these clinical findings, such as a narrow pulse pressure or muffled heart sounds or pulsus paradoxus, and whether or not it's beneficial to assess for these types of things. And given that with cardiac tamponade, the biggest thing that this patient requires is definitive surgical care or ED care to help alleviate that tamponade, I wouldn't be, you know, in the pre-hospital setting assessing for these types of findings. Pulsus paradox, that's a very difficult thing to assess for. It takes time and practice. We don't use that in the emergency department any longer. That was kind of a diagnostic test that was used before we had chest x-rays and CT scans. So we don't know any physicians who actually use pulsus paradoxus anymore in the emergency department. Again, muffled heart sounds, all different reasons why patients may have muffled heart sounds or quiet heart sounds. So again, these findings aren't the best for kind of determining if the patient has tamponade.
Mm-hmm. I think, as I said, bottom line, if these patients are hypotensive, you know, the one thing that's going to make a difference or potentially make a difference is giving fluids and rapid transport to the nearest medical center.
Yes, I mean, if these patients are hypotensive, then that's exactly what they're going to benefit from is fluid therapy, just to bridge them over until they do get fluid in there.
Another question coming in. So would gentler movement delay exsanguination? So handling the patient, would that? I don't think that's going to cause an issue. These people are bleeding out from a high pressure source, that being the aorta. So whether or not you transport them more gently or move them gently, that's not going to really cause any difference in outcome or extend the tear.
Another question coming in: are these patients ever mistaken with renal colic? And that's a great question, and you brought up a good point there. Kind of the teaching that we teach all our residents and medical students is a AAA until proven otherwise in an elderly patient presenting with renal colic. So
again, as the demographics show, AAAs develop over time, they enlarge over time. So they usually start after the fifth decade of life. So when people are in their 50s, that's when they start developing them. And they tend not to get to a size which puts them at risk for rupture until after the age of 55, 60. So those patients presenting with their first time renal colic at age 80, we're thinking AAA until proven otherwise. So yes, these patients can be mistaken for renal colic because, as you know, renal colic can have lower back pain, flank pain, radiating down into the groin, which is the exact same presentation as a ruptured AAA.
All right. Any other questions?
So a question came in, why is our fluid bolus protocol for cardiogenic shock only 10 mils per kilogram versus 20 milligrams per kilogram? When patients are in cardiogenic shock, that the pump is failing, it's not pumping well. So the use of fluids is to kind of bridge that to give them a bit of extra pressure. But the problem with cardiogenic shock is because the pump is failing, these patients are more likely to deteriorate into pulmonary edema with increasing fluid volume. So that's why the infusion is 10 mils per kilogram versus 20 mils per kilogram.
And to be clear, that these situations of shock that I've described with dissection, I wouldn't call that cardiogenic shock. For tamponade, that's more of an obstructive shock, so that would benefit from the 20 per kilo bolus. If they're exsanguinating, then that's more of a hypovolemic shock, and again would benefit from a larger bolus. Cardiogenic shock is more when the pump itself is failing due to either an MI or just kind of chronic heart failure.
And that's correct, because these patients have hearts that work fine, but it's being restricted. That fluid around the heart isn't allowing the ventricle to fill properly. So if that were to be alleviated, then the heart itself would be able to pump fine. So it's not cardiogenic shock, rather just a obstructive shock. Mm-hmm. Well, great. Thank you very much, Ben, for that presentation. Definitely informative, and two big bad types of presentations out there, and pathophysiology, presentations that have potentially very dire consequences. So two scary things that are out there on the streets that we may encounter both pre-hospital and emergency department. So thank you very much for everyone tuning in.
Thank you.
Until our next webinar, take care.
Have a good afternoon and weekend.